For the past 5 years, I've eaten a very high-fat diet. I've eaten lots of beef, butter, and eggs every single day, averaging 150 joule of fat daily. And yes, my cholesterol is high, but I'm not panicking over that number by itself because over the years, I've sat down with a lot of doctors. I'm talking a lot of doctors, even vascular surgeons and cardiologists, to see if eating beautiful butter and high-fat foods equals heart attack. But because I also like triple and quadruple checking, I sat down with another cardiologist, Dr. Michael Twyman. You can't tell who's going to have a heart attack just by looking at their cholesterol panel. Half the time, people have heart attacks in the hospital. Their labs are normal from a cholesterol standpoint. So if your cholesterol number doesn't necessarily determine what's happening inside your arteries, what should you be looking for? Well, in this video, Dr. Twyman covers the number one test he'd pick to determine whether someone actually has plaque building up in their arteries. Actually, less than 1% of people have ever had this test run by their doctor. And more importantly, we cover if you do find some plaquing in your arteries, what should you do? And if you like living your healthiest and happiest life, then don't be silly. Subscribe to Lily. Dr. Michael Twyman, as a cardiologist, what are the markers that you look for to assess someone's cardiovascular risk? As far as most people, they go to their doctor and get just a very standard cholesterol panel. Is that the thing that you would like to have done as well, to assess whether someone's on a trajectory for heart disease or not? What are the tests and U markers that you would look out for to assess cardiovascular risk? What's in your blood is interesting and important, but not until you know what's going on with your arteries themselves. So couple tests consider CT coronary calcium scores. Think of it like the mammogram for your heart. Calcium is supposed to be in your bones. If it's showing up on the CT coronary calcium score test, do you have plaque in your arteries? The higher the calcium score test, the higher risk of having a heart attack, stroke, or dying. People can also check carotid scans to look to see do they have inflammation in their arteries or soft plaque building up in the crowded arteries. So start with the arteries first. Do you have plaque? Then use the blood work to inform why. So lipids, they're important, but a traditional lipid panel is a poor risk discriminator. You can't tell who's going to have a heart attack just by looking at their cholesterol panel. Half the time people have heart attacks in the hospital. Their labs are normal from a cholesterol standpoint. Then there's people who have very, very high cholesterol and they have no plaque. So look at the arteries and treat the arteries. Cholesterol is just one part of those equations. But if you're going to check the lipids, it's more risk stratification, benefit to look at the lipoproteins themselves that transports the cholesterol. Think of it like cars on a highway. The more lipoproteins you have, more cars, more possible traffic jams in your arteries. So you can measure the LDL particles. You can measure something called ApoB or apolipoprotein B. Less than 1% of the population in the United States has ever had their ApoB checked. Kind of shocking. I've been checking it for many years. So in my mind, like everybody's had it, but less than 1% of the population even knows what it is or has had it ever checked. But what ApoB is a structural protein, and it's what holds lipoproteins together. So if you count up all the number of AOBs, you know how many agranic particles or plaque-forming particles potentially you have in your arteries. Having hypo does not mean you have plaque in your arteries, but it's like cars on the highway, more possible traffic jams. So you got to look at the art and see, is it a problem? If it is, you're going to want to have less cars on the highway. So less traffic is getting built up in your arteries long term. So I'm someone, and I share all my blood work online too, but I'm someone who has triglycerides of 30, HDL 60 or 70, HSCP, lipoprotein A, insulin, A1C, liver enzymes, kidneys. Everything looks great with the exception of ApoB. I can't seem to figure out this ApoB because I lowered my saturated fat. Had less beef, less butter, had more of the healthy fats, the olive oil. I had more fruits, more veggies, started doing zone 2 cardio, gets tested again. And I do not eat processed foods. I eat like very basic. And I got my lab work done a year later, and all of my markers went up, doing more of the good, healthy things and doing more of the cardio too. So my husband and I, we're just scratching our heads over here. We can do high fat, we can do high carb, whole foods, all, and still not seem to be moving the APO marker because ApoB in large portion is under genetic control. There's, thousands of genes that affect your lipid metabolism. So there is no way you can break something down and just call something good or bad. There's no such thing as good cholesterol, bad cholesterol. They're just different lipoproteins carrying things through your system. Cholesterol is not bad for you. Without cholesterol, you're not alive. I mean, you're using the cholesterol as a backbone to make certain hormones and bile acids and cell membranes. But if cholesterol is getting deposited into the walls of the artery and crystallizing and oxidizing, that's a problem. That's what you need to address. So when people have said, man, I've really cleaned up my diet, or I've never had a bad diet and I'm exercising and the lipids aren't changing, there's probably some genetic reason why their lipids are going to be that way. Then they can, do a test. There's a GB Health Insight test that looks at the 100 most common genes that affect your lipid metabolism, and then you find out exactly why that is going on that way. And sometimes that test will be useful to help people understand that, there's not going to be a nutrition lever you're going to pull on that's going to have a significant effect at this point. So then you're left with the decision are you interested in taking pharmaceutical interventions? Are you interested in trying different nutraceutical interventions? I'm relatively agnostic initially if the person is low risk. If they don't have a positive calcium score test or abnormal CR scan and they want to try lifestyle interventions, change their diet, highly recommend it. If they want to try some supplements, try it. But you only get a 3 to 4 month window trying supplements. Either your numbers get to goal or they don't. And then you decide, and oftentimes if you use the right blood test, you can figure out which pharmaceutical intervention may work for that person with the least amount of side effects. And not everybody's into taking pharmaceuticals. Understand that. But they're tools that potentially can help lower risk. And while you may be young now, if your lipids are a certain level now and is that way for the next 40 years, your arteries might not be so healthy. So there's getting to be an analogy sort of like cigarettes. If you smoked one cigarette, there's probably not a problem. You smoke 4 packs of cigarettes a day for 40 years, there's probably going to be some lung disease or heart disease developed along the way. And there's somewhat of a thought that there's these lipoprotein years. The more years your arteries are facing these high counts, the more likely the arteries will be insulted and plaque will form. So the earlier you can kind of bend the lipoproteins back into a 20th percentile, the less likely that person continues to go on to developing plaque. So again, back to the test, don't guess. It's get an analysis, get a test, do whatever intervention you want. Do you want to change up your diet to go paleo, carnivore, keto? Have at it. Then retest and see what did your labs do. Some people, they cut out saturated fat, their lipids improve. Other people has no effect. There's people that go high fat and they got an LDL cholesterol 500. That doesn't happen to everybody, so you have to test yourself. Where would you want to see someone's ApoB? What would be considered a healthy ApoB number? I would say a sweet spot is most people should try to aim for under 70, okay? Yeah, mine definitely is not 70. I was going to say that's like 102, but so 102 would be put you right around the 50th percentile. So 50% of the world has values higher than you, 50% has lower. And so that can be an okay number as long as a person doesn't have plaque in their arteries. And yes, I do believe it should be a goal that people are, quote, metabolically healthy and that they have low inflammation. So I know we mostly front-loaded the lipids, and you did mention lipoprotein A, and that is important. That lipoprotein A, everybody produces it, but only 20% of population has high levels. It's genetically determined in your liver how many of these lipoprotein AA particles you're going to make. But think of lipoprotein A as an LDL that turned into a baseball. It's much more likely to end your arteries. So it's more agrogenic and more thrombogenic. So more likely to cause plaque, more likely to form clots in your arteries. So at this time, there are no great drugs that significantly lower lipoprotein A, but it can double your risk of having plaque in your arteries. So you want to try to fix all your other risk factors. So if you have high lipoprotein A and you have a high APO, well, then you're going to have to do something to try to lower the LDLs that also have the APO, because you can't lower the LPA directly. And you only got to check that test one time to know if you have a high level or normal level. But lipids important. There's a couple other buckets. You mentioned many of the metabolic ones. So, where is your fasting insulin? Where is your fasting glucose? Your hemoglobin A1C, which is your 98 average blood sugar. Uric acid. Uric acid is a decent byproduct of how healthy your kidneys are. But how well do you metabolize protein, fructose, alcohol? The red wine question. If you don't process that stuff well and you're having high uric acid because of it, the high uric acid damages the glycoalix, the lining of the arteries. The high uric acid is the problem. So if you want a lifestyle intervention there, yes, remove things that are raising it in that case. And homoyine is another amino acid that can potentially damage the arteries. And then you can look at the other ones that tend to affect nitric oxide and inflammation. So HSRP is a global marker of inflammation. But LPLA2 and myoproidase, those are specific to the vascular system. So while CRP can be high because your knee is inflamed, LPL2 activity and myoproxase are high because your arteries are inflamed. You have fire in your arteries, and those are the people at higher risk of having heart attacks or strokes. We've been talking about a lot of different things that can affect your cardiovascular health, like your blood sugar, blood pressure, inflammation, and metabolic health. But one thing that's often overlooked is just how important the basic nutrients are for your body. Electrolytes are a really good example of that. Sodium, potassium, and magnesium aren't just things to think about when you're working out and sweating. They're essential for nerve function, muscle function, and maintaining normal heart rhythm. That's one of the reasons I like today's video sponsor, Element Electrolytes. I just pour 1 packet into water, shake it up, and I've got a yummy drink that has the science fact ratios of sodium, potassium, and magnesium that again are so essential for our hydration and heart health. Element also has a bunch of different flavors like watermelon, citrus, raspberry, and I especially like putting the chocolate salt in my yogurt, or my husband will put it in his coffee. This is a clean ingredient electrolyte brand that helps me drink more water, since sometimes plain water is quite boring for me. And this is an easy way to help me with drinking more water and staying hydrated. If you'd like to help support this channel and get 8 free packets of Element's most popular flavors with any order, then click the link in the video description, drinklelement.com/Iliane. You had also mentioned some supplements may be helpful first if someone didn't want to go through a medical intervention initially. What would be the supplements that would be beneficial? It does depend. I mean, you can use the red yeast rice or bergamot, and there's a supplement called berberine. Berberine's helpful for blood sugar regulation, kind of like metformin would be, but it does have an effect on the elder receptors. So the elder receptors are what are grabbing the tennis balls out of the circulation, delivering it back to the liver. So if someone has testing done and they see that they do have plaquing in their arteries, is there hope still? Can they reverse this, or is it too late? Yeah, it's never too late until you don't have energy in your body, so never too late. But if you have high insulin, high stress, high heavy metals, pollution, high blood pressure, then you're setting yourself up for plaque. So it's kind of think like endothelial dysfunction is the first stop in the subway. If you don't fix it at the second stop, you're going to have thick arteries, inflamed arteries. Third stop is you have plaque. And then the fourth, fifth stop, you're rupturing these plaques and having heart attacks or strokes. So you want to find the person as soon as you can and try to stabilize it. We've covered a lot of different markers that people could have tested to assess their inflammation, their metabolic health status. But if you could only choose one, what would the one test be that people would want to have done to assess if they're doing damage to their arteries? While it is not a perfect test, if I could only get one, I'd recommend most people consider a CT coronary calcium scan. So if you've already had a heart attack, stroke, stance, or bypass, this test is not for you. You're already high risk, treat as such. But this is for people who are more thinking that they're low risk. The CT coronary calcium score test is a low-dose CT scan. It takes less than 5 minutes. You do not require an IV. Most locations, it's maybe between $100 and $200 to do it, and insurance generally will not cover the test because it's a preventative test. Now, I believe Texas has a law that it is covered by insurance, but the greatest majority of places, it's a cash pay test. And any primary care doctor can order this test. You do not need a cardiologist or heart specialist to order this test. But this test really helps risk stratify. Are you low risk, your score is 0, or you're high risk? Your scores over 300 is equivalent that you've already had a heart attack even if you've never had a symptom. So the higher the calcium score, the more plaque you have in your arteries. So 400 is considered high risk. Over 1,000 is very high risk. Those people, approximately 1 in 3, will have a heart attack in the next 5 years, unless you do something about it, maybe 10 years. And the highest score I've ever seen is well over 7,000. So it's a long kind of pathway that say like, oh, you're still 0, then whatever you're doing must be working for you. Whatever diet you're doing, whatever supplements, meds you might be doing is working for you. But if your calcium score 7,000, you have passed a 5-alarm fire in your arteries and you're extremely high risk of having a cardiac event. So those are the people that need to be as aggressive as possible with all the risk factors that they can modulate. So the calcium score test, again, is kind of like the mammogram for the heart. You know, if people are willing to start doing mammograms at 40 and colonoscopies at 40, 45, 50, whatever the new guidelines are telling people to do, they should be looking at their vascular health as well, because still, unfortunately, to this day in 2026, vascular disease is the #1 thing that still kills people early. So it's detectable with non-invasive testing, and there are a lot of good options to try to help stabilize the plaque, because just because you have a plaque doesn't mean you're automatically going to have a cardiac event. You want to die with the plaque, not from the plaque. Yes. One of the things you also mentioned is that somebody could have a heart attack already, even if they didn't actually have one. So can someone be completely healthy and fine, feeling, oh, I have energy, I'm sleeping good, and be that same person who you just talked about, or typically they would have already other signs and symptoms like, oh, I have heart fluttering, I get lightheaded and dizzy, I can't exercise for very long without feeling winded. Are there other silent signs that someone's already on this trajectory for heart disease? So typically when people say silent heart attack, there are people who have actually had an infarction in the heart. Tissue has died, and they had no symptoms leading up to that point, or minimal symptoms that they didn't realize it was. Their heart tends to be more common in women, tends to be more common in people who are diabetic. Diabetes can damage nerves, and then you don't necessarily feel the same things. But when I said when it's like equivalent of having a heart attack, the calcium score test, if your score is 300 or higher, you're in the same risk category as the person who's already had a known heart attack, and you should be treating your blood pressure, your lipids, your insulin resistance as aggressive as possible. If you've already had a cardiac event, if you missed the first part to the conversation with Dr. Twyman, I show him 20 different foods and have him rate them: red, yellow, or green. Red being bad for the heart and green being great for the heart. It was a very eye-opening conversation, even for me, because we cover things aside from food that he thinks are bigger drivers of heart disease, heart attacks, and cardiovascular events. You're not going to want to miss that video. I will link that right here and in the video description. Don't be silly.